We're now going to go ahead and talk about the ear, which is responsible for hearing and balance. And it has a nerve that manages those two sensory components of our appreciation, and that's the vestibulocochlear nerve, which is cranial nerve 8. We're going to start with what most people relate to as the ear, but what really actually takes care of us is the middle ear and the inner ear, and more specifically the inner ear, because that's where transduction occurs. Remember, transduction is taking a physical event and creating an electrical event, and it's the electrical event that actually reaches our cortex. Hearing and balance, or equilibrium, is another term you can use for balance. Taking a look at the ear, the outer ear or external ear, everybody sees the auricle or the pinna. It's elastic cartilage covered by skin. And what do you know about the application of the skin to the elastic cartilage of your ear? Is it pretty tight or is it pretty loose? How would you actually quantify it? Pretty darn tight. And so one of the things that you have to realize, it's just actually covering and protecting that elastic cartilage, allowing some structure for that little megaphone type of a device to actually bring sound and accumulate it into the external acoustic meatus. But it is elastic cartilage, and what do you know about its vascularity? What do you remember about vascularity and cartilage? None, that's right. You can say that too about elastic cartilage. It's the same thing as hyaline cartilage. The difference between fibrocartilage and elastic cartilage and hyaline cartilage is the types of fibers that are thrown into hyaline cartilage. You guys follow that? You have the foundation's hyaline cartilage, and then you throw in a bunch of elastic fibers, and you have, therefore, now elastic cartilage. Fibrocartilage is you take hyaline cartilage and throw in a bunch of collagen fibers, and then you have fibrocartilage. So it's avascular, and so when somebody gets a piece of their ear lopped off, what happens? Do you do it like somebody gets their finger lopped off? Take that finger with you and put it on ice and take it to the emergency room and see if you can get it sewed back on? Will you do that with your ear? No, you cannot. And that's because of that cartilage, that elastic cartilage, the avascular, does not repair well. So all you can do is get a sealing of the edge of the cut and then actually put some skin over that area to cover it up. So it's not a good idea to actually deform your ears. Though people do all kinds of things to their ears, they do all kinds of piercings. Most commonly, do they pierce that area where the elastic cartilage is located? No, they pierce it in the area where there isn't elastic cartilage. Though some people are piercing in the area where the elastic cartilage is, correct? The difference is, if they decide they no longer want to wear a piercing in that area, will that hole ever close up? No, that hole remains permanent because of the nature of elastic cartilage. Whereas if you actually have people that have dilated their earlobes, that's an interesting trend. I thought, I was like, oh man, that's going to be a lot of fun when the little kids come at you with their hands and grab them and yank them on down. It's already bad enough with earrings, much less huge lobes laying on your shoulders. But well, you think those things, don't you? You know, I know I'm not alone. That's why you guys laugh, because you want to say it, but you're afraid to say it out loud. You know, sometimes. Some are not, some are. So the thing is, though, when you actually start dilating those earlobes, if you take the dilator out early enough, it will actually repair for you. And so you don't have to undergo any sort of plastic surgery. But if you leave it in too long, as many things can happen, is you'll actually have to have plastic surgery repair if you no longer desire that unique look in life. So that's the auricle, elastic cartilage, and skin. Yay. The external auditory meatus, also in our notes, it says external acoustic meatus, acoustic and auditory, basically synonyms for the same word. So it's the same. Inside that, what is the lining inside our ear canal? Stratified squamous epithelium, and it is actually still keratinized. We do have ceruminous glands, which are modified sweat glands, and they produce that lovely material called cerumen, which we call earwax. And it's protective. It helps to keep that area moist and also has antibacterial or bactericidal properties to help maintain the patency of that canal. The tympanic membrane, often called the eardrum by most people, is shaped like a flattened cone protruding into the middle ear. So that means it's pointing medially, but it is still pretty flat. It just has a little bit of a point to it, and that goes medially or nasally. One of the things about the tympanic membrane or eardrum, it is fibrous CT for the most part. But on the outside, it has a layer of protection. So what would that layer of protection be on the outside of the tympanic membrane? Stratified squamous epithelium. Also thin skin. Isn't that basically what we have in this area? So thin skin on the outer surface. What do you suppose we have on the inner surface? Now it's inside your body with contact to the outside world. Mucosa, that's right. So mucosa is lining the inner surface and thin skin's lining the outer surface. Now the tympanic membrane, because it has that combination of thin skin and mucosa, has the ability to actually repair. And we'll talk about that in a minute when we actually talk about problems with the eardrum when we get into the middle ear. So let's take a look at the middle ear. Here is a view of it from here with an extension called, I call it the eustachian tube, you can call it the auditory tube, and we can call it the pharyngotympanic tube. So we'll learn all of those names for it. But let's take a look at a larger picture of that middle ear. It says it's an air-filled, exposed to the outside world. So air's pretty much what we would expect to see if you're exposed to the outside world. Air-filled mucosa-lined cavity within the temporal bone. And that is true. All of this, as you guys know, is within the temporal bone. Even the external acoustic meatus is within the temporal bone. So we have middle ear in the temporal bone, and inner ear is also in the temporal bone. Remember that temporal bone on the inside, it had this kind of bulky ridge in that? That's the petrous portion of the temporal bone, and that's actually where all these items are actually now located, our middle ear and our inner ear. One of the things that we need to talk about is the structures and the items that we're going to find in here. Let's start with A, openings associated with the middle ear. Well, they're not true openings, they're potential openings. There's only one true opening, and that's the pharyngotympanic eustachian or auditory tube. In our notes here it says external auditory meatus. That's not a true opening because it is sealed by the tympanic membrane. It's a potential opening. Oval and round windows. Those are areas that lead to the inner ear. The oval window is always associated with the stapes, and the round window has nothing other than a mucosal surface over its membrane. And so those are portals into our inner ear that are strictly associated with hearing. So something to keep in mind with that. And those are just potential openings. If you had a true opening with those things, you would actually have hearing loss with that. Auditory tube. Here in our notes, a pressure equalizing tube leading to the nasopharynx, also called the pharyngotympanic tube, and eustachian tube. This is ordinarily collapsed and is open when you do certain maneuvers. And you do that when you're venting the auditory tube or the eustachian tube, correct? You can make it pop. And what's one of the more common maneuvers to make it pop? Plug your nose, close your mouth, and blow, right? Okay, you're opening it then. That's why I tell you it's ordinarily collapsed. When we get into the digestive system, we're going to find out our esophagus is ordinarily collapsed and is only open when we swallow food, which makes sense. Otherwise, you get air in your tummy all the time and be belching a lot, or the other end. So with this guy, with the auditory tube, it can be opened artificially by backwards pressure, but another way that you can open it is with jaw maneuvers. You can actually manipulate your jaw, which is pulling on the soft tissue, which will temporarily open it. Also, swallowing also helps to do that. Often when you yawn, you can actually hear the popping in your ears. And the popping in the ears reflects a phenomenon of mucosa. What do you know about mucosa? What's so important about mucosa that makes it nice and protective? It produces mucus. So if it's a mucosa-filled cavity, if your middle ear is a mucosa-filled cavity, it produces mucus, right? And mucus, if it's overproducing mucus, then you get an accumulation, and you have to make sure that auditory tube is opened enough in order to drain it, because that's part of what it does. It's not just in pressure equalizing, it's a method for draining the middle ear. And so if you hear crackles, what does that tell you? Yeah, you have fluid in your middle ear, because hearing crackles is a reflection of some sort of head cold or allergy phenomenon, more often head colds. And in order to get that fluid out so you feel like you're hearing better, you have to vent your eustachian tube a lot more frequently, yawn, chew gum, or things along that line. So that's one of the phenomenons. Now, the other thing about the middle ear, kids have a lot of problems with their middle ear. Do you know that? What kind of problems am I referring to? Ear infections. So that means in this mucosal-filled cavity, there can become bacteria in there. How do the bacteria get in there? Nasopharynx. Little kids get colds, yes? All the time. You just look for a day or two when they're well, you know. So they get colds all the time, and so they get bacteria, you know, that actually can then kind of overpopulate, and then they just walk right on up that auditory tube into that mucosa-filled cavity, and then they're like in a land of bliss. And so then they create their infection, and when they create their infection, do the kids complain about it? Many times they do, especially when it's really bad. You know, they'll have fever maybe, or maybe not. Because what you can do is you get an infection in there and it causes swelling, right? Doesn't infection cause swelling? And swelling basically ties off the auditory tube. When you tie off the auditory tube and you have a festering infection here, what is it? Does it just stay small? Does it grow? It grows. What does it do to the tympanic membrane and all the structures associated in that area? It just pushes that tympanic membrane in what direction? Out. And that hurts. And do they hear very well? No, because of these lovely little ossicles or little bones, which are a bridge from the tympanic membrane to the next very important membrane of the oval window. So they will actually dampen the effect of the ossicles in that area and transmitting sound to the next area that we need to do a transduction event. So one of the things that happens when it's really, really bad, suddenly you'll see pus running out of their ear. If pus is coming out of their ear, where's it coming from? It's coming from a hole in the tympanic membrane. Just like any other boil, they always feel a lot better when they burst. And so then they will be less complaining, and there'll be pus running out of the ear, and there'll be a hole there, and that's because this infection wants a way out, and it cannot come out because it's been strangulated, so to speak, because of swelling of the eustachian tube. So for those kids that have recurrent ear infections, what's a frequent surgical procedure that their parents will get done on them? Tubes placed. And you can place a tube and make a hole in that tympanic membrane, because the body will do it if you don't. And they'll put a tube in there, and when they continue to grow, and finally what's really nice about kids, when you know that they're going to be less prone towards ear infections, because suddenly you notice that they have a neck. Because part of the problem is the auditory tube is more flat when they're little kids, and then as they grow and their neck grows, the auditory tube comes at a more natural angle and helps to provide proper drainage for them. Hard to drain when you're horizontal, easier to drain when you've actually got an angle associated with that. So the myringotomy tubes, as they grow, end up falling out, and what do we know about the ability of the tympanic membrane to repair itself? It's got mucosa on one side, so mucosa repairs nicely, doesn't it? And it's got thin skin on the other side. What do we know about thin skin? Repairs nicely. So we end up with a nice natural repair of that tympanic membrane. So that's an important thing to realize. Now, another thing I want you to realize about the auditory tube, or the eustachian tube, which is what I prefer to call it, old stuff, you know. It's hard to change your ways. I keep trying though. Okay, I want you to think of this middle ear cavity like a balloon. Because remember, it says air-filled and the eustachian tube or auditory tube is an equalizing tube. It's not equalizing just air, because we also learned it's equalizing secretions, getting secretions out. So now I want you to pretend, though, that mucosa inside there is like a balloon. And it's got air inside of it, just like a balloon does. Okay, and so now you're going on a trip. You're going to fly to Hawaii for a break from this gloomy weather. And so you go up. And what do we know about balloons that go up in the air? They expand. And so what do you know if you happen to have a little bit of a head cold and have difficulty venting or opening up this eustachian tube? What do you know about that little mucosa-filled cavity? What's it going to wish it could do? Expand. And so what area is mobile that will actually move when we have this pressure to expand? Tympanic membrane will then point out. That's right. And that's painful. And so one of the nice things is, because you're going up and everything expands, even if you have a head cold, you're able to sort of temporarily vent your eustachian tube. Swallow, yawn, jaw maneuvers, plugging your nose and blowing, with your mouth closed type of stuff. You're able to do that, so you're able to mitigate the pain. Now you've taken your flight, now you're on the descent, and everything's nice and sunny. You see the beaches, you see the blue ocean, but you go, oh, this pain. Why are you having pain on descent? Now everything inside is being like a balloon. It's being pulled inward, yes? Because we vented when we were up, which means we lost some molecules of air, so to speak, because the further up we go, the less air molecules we have, correct? Now we're coming back down, and we're unable to vent or equalize the pressure of that chamber to our outside world. And so it's starting to be squeezed on in, so the tympanic membrane is being now moved in what direction? Medially or nasally, and that also causes pain. And all that mucosa is trying to crinkle on up, and it's causing pain because of that, in effort to make you open up your eustachian tube or vent it. The problem with descent is, when you're going up and you have a closed space and you're going up, it's easier to open the closed space when you're going up with the pressure pushing it open. But when you have a closed space because of swelling and you are going down, it's being sucked closed more. You guys follow me with that? And as you try to make it open, it's harder to make it open. So it's always the descent that's tons more painful than the ascent. And then you always know this when you have a kid on board. Somebody's brought their baby on board with a head cold. Because what does the baby do on ascent and descent? Cries. And that's why the parents try to feed them. They don't realize that they're actually, with the swallowing maneuver, the baby will actually open or vent their eustachian tube for a little bit, but sometimes on the descent, the babies can't do it because the parents have decided to fly when their child is sick. Mean, mean parents is my opinion. Now let's go to the auditory ossicles, tiny bones connecting the tympanic membrane with the membrane of the oval window. So what this is it's a bony bridge. This is a tension bridge. This is a nice swaying bridge. So we have three ossicles. We have the mallet, we have the anvil, or the incus, and then we have the stapes. So malleus, incus, and stapes, mallet or hammer. Incus is anvil, and stapes is stirrup. And so, the anatomists found these teeny tiny bones, the smallest bones of your body, and gave them names for what it reminded them. And these are teeny tiny bones that have, between the malleus and the incus, synovial joints that are connecting these ossicles. So one of the reasons why kids don't hear so well when they have ear infections is we have, instead of air around these bones, we have fluid around these bones, which will dampen the vibration of those bones. And we don't want to do that because that seriously impacts hearing. And so that's one way that you can actually experience hearing loss, but because these are synovial joints, what's another thing that we know can happen to synovial joints as we age? Mobility. Yeah, mobility or arthritis, right? Isn't that what they call, when you can't move your joints so well? So these, there is a unfortunately rare cause of hearing loss that is actually related to an arthritis here of these little teeny tiny synovial joints. Some other things associated with that middle ear. So the middle ear is a very vital structure in your hearing. Are two tiny skeletal muscles. Who would have thought they would have been skeletal muscles? Because mostly when we talk about muscles where we don't think about we have any control over, it's always been smooth muscles. Well, now we have skeletal muscles, which means that we can control them. The diaphragm, by the way, what do you think the muscle is of the diaphragm? It is skeletal. So when we need to control a muscle, it has to be skeletal, but that doesn't mean all skeletal muscles are only under voluntary control. So these guys are also under autonomic control as well as voluntary control. So we can override autonomic, so to speak, but who would want to? Okay, tensor tympani is attached to the wall of the auditory tube and malleus. The stapedius is attached to the posterior wall of the middle ear and stapes. Let's go up and take a look at our little picture here. I'll do some erasing so we can see a little bit better. So here's our tensor tympani, and the notes here say it's cut, so it does kind of go around the stapes, but it does not come into contact with the stapes, and you see it going all the way here to the malleus. And so that is going to tense the tympanic membrane, tensor tympani. You guys follow me with that? So when you tense the tympanic membrane, how well will it vibrate when you hit it? Less well. And so if a noise is really loud, would you employ this maneuver? Such as when you're firing a gun or fireworks and you don't have any protective hearing associated with it. So tensor tympani is one of those things where we actually tense the tympanic membrane so that we can actually be able to tolerate a loud noise close by. Same thing with the stapedius, this little guy down here. He's a little itty bitty thing. So he is tensing the stapes, which is attached to the oval window, so that when the stapes is making its inward plunge on that oval window, it's not going boom. Because when that happens, ultimately it will cause you to kill hair cells, which means it will do what to your hearing at that frequency? It will damage it or delete it for you to where you no longer have it anymore. Because the hair cells are our modified neurons that are going to help us with actually hearing. So posterior wall of the middle ear plus the stapes, and both of these are going to dampen vibrations. Of this bridge so that we do not damage the inner ear or the cochlea. So now we're going down to the inner ear or internal ear, and I want you to realize it's within bone, and the outline of it within the bone is called the bony labyrinth. And then inside we have a lot of nice soft fluid-filled membranous portions called the membranous labyrinth. One of the ways to think of the bony labyrinth is a snail shell, for example, because that's our cochlea, embedded into, let's say, some sort of material like concrete. That's just an example, because the temporal bone is essentially the concrete, and we put a snail shell in it. So that's what we're talking about when we talk about the bony labyrinth. It is bone on the outside that is creating or even a plaster of Paris cast. It is bone that's for its demarcation, and it's lined with endosteum, which is inside. Do you guys remember periosteum and endosteum? So endosteum is always inside bone that has no exposure to the outside world at all. And in the bony labyrinth, before we even get to the membranous material inside, there is a fluid called perilymph. We have two fluids. We have perilymph, and in our membranous labyrinth, we'll end up with endolymph. So we talk about the difference between, because you could say, well, there's fluid in all these areas. Why is it not all called the same? Because the chemical composition differs. And it's because of the differing chemical composition that we are able to activate our neurons. Endolymph has the proper composition for neuron activation. Perilymph is meant to be supportive, like CSF, cerebral spinal fluid. It's supportive. So perilymph is supportive. Endolymph is the material, the fluid necessary to actually cause a neuronal activation process. Transduction. That's where we're taking a physical event and changing it into an electrical event. Another way, since we're using snail shell in our bony labyrinth example, snail's body is inside the snail shell. And you can liken the snail's body to the membranous labyrinth, and it's filled with the endolymph. So we have a bony encasement, and then we have all this membranous material on the inside. And so when you see the models in lab, you have to realize all of that material that you're seeing, the bone was melted away. And that's what actually is the final border between the various areas of the inner or internal ear. Three exceedingly important areas of this inner ear. The cochlea. So this area that looks like a snail shell is the cochlea, and that is Latin for snail shell. Then in the middle is this area called the vestibule. By the way, this one is, the cochlea is the one for hearing. And then the vestibule and the semicircular canals are for balance or equilibrium. So the vestibule is the next area. And remember, vestibule is this big open area. So sometimes they call this an egg-shaped area. And then we actually have semicircular canals hanging off of the vestibule. So the vestibule is in between the cochlea and the semicircular canals. The vestibule and the semicircular canals are both responsible for equilibrium or balance. I often call the semicircular canals hula hoops. And as we will see, that circular structure of the semicircular canals where they actually plug into the vestibule in an area that's a swelling, which is called the ampulla. So swellings are called ampulla, or ampules in the medical field too. So that's a term that you'll use out there in your practice also. Let's take a look at the notes. One of the things I recommend for you guys in any of your histology drawings is it's never a bad idea to have a low power drawing, so that when you take a look at something from low power, you already know where you are. And this is a really good area for a decent low power drawing, or something along this line, because this is actually taken from that. To me, this looks like a stalk. This guy here looks like a stalk with flower buds off the side, you know, if I were to draw something along that line. So drawing it isn't going to take you that much time, but it's important that you realize sometimes a low power view gives you a lot of information. This is the cochlea or the snail shell, and then you're going to need to have something like this in your drawing, because that is where the actual spiral organ of Corti is, where hearing actually occurs with those guys and those hair cells. But back up to the notes here. 3 parts described in detail. Vestibule, central egg-shaped cavity. Within the vestibule are 2 important static equilibrium receptors. The utricle and the saccule. The static equilibrium receptors within those guys are actually called the macula. The actual area where transduction occurs. Maculae for plural. So utricle and saccule, one is horizontal and the other is vertical in its kind of placement in the vestibule, and it's not important that you memorize which one's horizontal and which one's vertical. But one is horizontally located, the other is vertically located. So these are sacs in the vestibule that have endolymph inside them surrounding or bathing the macula. Then, more for balance and equilibrium, because that's what we're doing here with the vestibule, are the semicircular canals. Our notes here say it extends off the posterior part of the vestibule. Indeed it does. And we have anterior, posterior, and lateral semicircular canals. Within the semicircular canals, just like within the vestibule was a utricle and saccule, within the semicircular canals are semicircular ducts, and these 2 are the membranous sacs within the canals that contain receptors for dynamic equilibrium. And those are called crista, or crista ampullaris, but we'll call them just crista for short. Cristae for plural. So those guys are surrounded by also endolymph that are responsible for an interesting arrangement of hair cells for activation. So hair cells are very important in all 3 of these structures to actually cause transduction into a nerve signal. Cochlea, snail shell, also contains its membranous labyrinth tubes, but there are 3 names, and these 2 are continuous with one another at the tip of the shell. The scala vestibuli, that's awful, and the scala tympani have a connection at the very tip of the snail shell, or top of the snail shell. And that's why they both contain perilymph. Remember, perilymph is supportive. Endolymph is what we need when we actually have to have transduction into a nerve signal. The scala vestibuli abuts the oval window. Scala tympani abuts the round window. And because we see endolymph, we know that's where we're going to have the important stuff here in order to allow us phototransduction. So they call the scala media, also referred to as the central duct, or cochlear duct, and that contains the spiral organ. And because they're trying to get away from using people's names, they just call it the spiral organ now, but you'll hear me always call it the spiral organ of Corti, just like eustachian tube. And the reason I tell you certain things along this line is when you go out there and you're dealing with a practitioner, they'll say eustachian tube instead of auditory tube. And so when you're out there in the real world where you're practicing with other healthcare providers, what we learn here in A&P is not always the words that's used outside in the real world. And so I try to remind you of those things by including those names. So the spiral organ of Corti is the one that's really important. Just like the cristae are important, the spiral organ of Corti is important, and the maculae are important because that's where we're going to generate the electrical signal, which will go to the brain, which will give us a perception of hearing or balance. Let's start with hearing, physiology of hearing. Sound. Sound, our definition of sound right now is a pressure waves originating from a vibrating object. And that's what you did with the tuning fork, right? When you popped the tuning fork and you saw the times they were vibrating. And the important thing to realize that sound is, it says here, pressure waves. And so what you're hearing is a compression of molecules hitting the eardrum and then not so much. Compression, molecules hitting the eardrum and then not so much. And that causes the eardrum to vibrate because of those pressure waves. So even if you make you mess around with your ear and you make air go fast at your eardrum just by air itself, you actually can hear it. And so that pressure, it's not as intense as a sound wave, but that pressure wave is molecules compressing and causing the eardrum to then vibrate back and forth. And this is important because this is what we need to actually start the movement of the first item necessary to create that phenomenon called hearing. So sound waves, they travel through various mediums. As waves in alternating high and low pressure areas. Which travels, so interesting, light is waveform and sound is waveform. Which one travels faster? Light. And also light is blocked by various structures, correct? Whereas sound is not necessarily blocked by various structures. So you can get sound waves that will pass through more solid structures, whereas light will not pass through certain solid structures. So sound waves travel slower than light. Waves. And we come up with 3 terms here for our sound waves that we all intuitively know, but let's make sure that we can know for an exam, not just natively or naturally. Frequency, amplitude, and wavelength. Wavelength is related to which of the 2 above it? Frequency or amplitude? Frequency. So wavelength is related to frequency. So let's talk about, so you only have to learn 2 things, and then you have to remember how the wavelength is related. So frequency is how many sound waves per unit time. And remember, it's sound waves, it's just like that. How many sound waves per unit time. And the other is amplitude, the height of the sound waves. And so I can change my amplitude of that frequency by doing this, right? So frequency to me, and then this is amplitude. I increase the amplitude. If I decrease the amplitude, the waves would be smaller, but they would still be the same frequency. Which one is pitch of those 2? Pitch, high pitch and low pitch. Frequency. So frequency is pitch. What's the common symbol that we use for pitch with tuning forks and stuff to indicate what the frequency was on the tuning fork? We'll get to it in just a second. Amplitude, height of the sound wave. Another word for that if you're describing it to your kids? Amplitude is loudness. What do we measure loudness in? Decibels. Here we go. Now we're starting to go. Decibels. And so pitch, what do we use for measuring pitch? Hertz, right? Or VPS, vibrations per second, CPS, cycles per second. So pitch, because we have high pitch, we have low pitch. Okay, I'm not very good at low pitch, but we get the gist of it. And amplitude is like this and like this. So you have your own little methods for memorizing things. Wavelength, the distance between 2 crests in a sound wave. So if I have high frequency, high pitch, what do we know about the distance between the 2 crests of that sound wave? Small. We have short wavelengths. Absolutely. Now, transmission of sound is really interesting. We have to get it into the ear canal, or the external acoustic meatus or auditory canal, and then it has to strike the tympanic membrane. And once it strikes the tympanic membrane, as we see here in this picture down here, it starts to cause the tympanic membrane to vibrate at the same frequency that the sound had or has, as long as you continue to listen to it. So it will vibrate at that frequency, at that pitch, and it will cause our bony bridge here to also vibrate at that same frequency, and it will cause these stapes to push in on the oval window. And in this area here is all, in the cochlea, we have all this fluid and membranous material within that cochlea. Now, one of the things I want you to understand about going and trying to move fluid versus trying to move air, which is easier to move? Is it easier to move air, or is it easier to move fluid? Air. Okay, so now we are trying to go from air causing the tympanic membrane to move to now we're trying to push on this other membrane that has water or fluid behind it. So we need to actually amp up the force. And that's one reason why the eardrum is 20 times larger than the oval window, because when you take a look at that, the eardrum here, and then that area where the oval window is with number 3, that's a much smaller structure, and it's 20-fold difference. So we are able to multiply force on oval window 20-fold. So we can then generate a fluid wave, because now we want to generate a fluid wave. So we have a lot of resistance to do that, and so we need a little additional force. Now, when our membrane, our tympanic membrane, is vibrating with the same frequency as the noise that we're hearing, the ossicles also vibrate at the same frequency, or move or hinge. And so we're trying to move the oval window also at the same frequency that the tympanic membrane was moving. Now, we have, I don't know if you realize there's a bit of a problem. So the snail shell is an enclosure, okay? And we are at an opening, the oval window, and there's all this fluid in there. And I liken it to, just to simplify it in my head, I liken it to a box full of fluid that's just completely filled with fluid. And I am trying to push in on that oval window. How well am I going to actually be able to push in and create a fluid wave in that chamber with just this one portal? It's like, how well can you push on fluid to make it actually create any sort of waveform function if you're just pushing on one area? That is the reason that we have the other window, right? The other window is there so that we can actually generate a true waveform. Because when you push down on the oval window, what will happen to the round window? It moves outward. And indeed, that is part of the phenomenon of this fluid wave that we're creating. In order to actually create a good fluid wave, it has to be able to travel. In order to do that, we actually have to have an area that will actually allow movement. And that's part of what the oval window is all about. Back to our picture here, number 3. We're at the oval window. We're going to create a fluid wave in the scala vestibuli first. So in the scala vestibuli, there will be a fluid wave, and it will go all the way to the area where resonance occurs that is related to the frequency. So we take a bend through the scala media, or cochlear duct. And then what's really weird about this picture, it's like somebody got off like they're a worse artist than I am. Because this little squiggly that you see is supposed to be in the fluid, people. That's why I say they're a worse artist than I am. And so then we're going to create a fluid wave in the scala tympani. And the area where we go through the cochlear duct is very important because we have to get into the scala tympani and push up on this area that is called the basilar membrane or basilar membrane, because that's what the spiral organ of Corti sits on. And you have to push the spiral organ of Corti up to where the hair cells bump up against the tectoral membrane in order to actually do what I call sound transduction. So to create an electrical event. So the hair cells in that area have to be pushed up into the tectorial membrane. And so you have to move the basilar membrane up. It's not this, when it first comes down in this area is not important. It's the first upward bump that's important for the basilar membrane to actually help with the transduction to an electrical event. We'll talk more about that when we get together next time on Monday, but that phenomenon where it moves through is related to resonance. Resonance is related to hertz or frequency. or loudness, or not loudness, or pitch. And so I want you to, I'm going to ask you to think on this, because wherever it goes through, it tells you the pitch that we're actually experiencing. And it's all about teenagers on a summer day in their car. You're sitting at a stoplight and you hear them coming. What pitch do you appreciate? It's the bass. It's the low pitch. And so it's going to travel further down our scale of vestibuli before it does that resonance. And so when they pull up next to you on that lovely summer day, you can hear the rest of the music. You can actually hear the higher pitched frequencies, yes? When they're actually next to you. And so those don't travel as far. So we don't travel as far if we are short wavelengths or high pitch, and so our high pitch will actually have its resonance in this area closer. Low pitch further on out. That will be all for today, and sorry I took a few moments extra.